Good morning, and thank you very much to this kind invitation to Manos, and a special thanks to the moderators, because this is a wonderful meeting, and I'm sorry, these are my disclosure with no conflict of interest for this kind of presentation, and my topics regard the augmenting rotator cuff repair with grafts. And when we consider patches and rotator cuff, we know that the aim of the use of this kind of reinforcement is to improve our results in terms of tendon healing. And in literature, there is a great interest about this issue because, above all in the last period, in fact, we can find some reports about different techniques and different scaffolds. Gore-Tex, polylactic acid, this is for biomechanical reinforcements, and porcine dermal collagen for biological effect, even if with a small number of patients, but with an encouraging results. But if our main aim is to promote the tendon healing, we have to consider the biological scaffolds only. And in 2014, Bezel demonstrated that the non-cross-linked porcine collagen scaffolds showed superior results for cell adhesion and proliferation, as well as on histological evaluation. And in 2015 and 2016, other studies investigated the role of the biological augmentation with different techniques, indication, but at the end, in this review, the author established that we mean what we mean when we talk about the ideal scaffold that should have an adequate initial and mechanical properties, be slowly degrading, have no toxic degradation products, enhance cell growth, infiltration, and differentiation, promote regeneration of the tendon interface, be biocompatible, and have excellent suture retention and dangling properties. And these are the same characteristics that Arnowski described in 2008 for the ideal patch. And in order to provide mechanical reinforcement to the primary repair, a scaffold incorporation to the host tendon, gradual replacement of the scaffold by host tissue, support the regeneration, and this is possible if the patch is not cross-linked, and it's necessary also that the patch should be no antigenic and sterile and ready to use. So the last year, we presented at the ANA meeting the results of our study, where the purpose was an MRI assessment of the anatomical integrity of the medialized single row rotator cuff repair, augmented by porcine dermal membrane versus not augmenting group. The membrane was, our patch was a porcine dermal tissue, sterile, ready to use, not cross-linked, and with alpha-gal removed. And the study has been prospective, monocentric, randomized, controlled, and the sample size was calculated by the Pearson-Kidd square test with a healing proportion of 40% in group B, no patch, and in the versus 70% in group A with a patch. And the number of patients was 46 for each group. Our inclusion criteria were the age between 50 to 80, the degenerate tears, anterior superior, superior, and posterior superior tear, early or late according to Ellman retraction type, negative or neutral Fuchs index, and 0 to 2 Boutelier infiltration grades. And the exclusion criteria were concomitant shoulder pathologies, previous surgeries, corticosteroids injection in the 6 months before the enrollment, connective tissue disorder, infective, and rheumatoid disease. The surgical technique was based on the standard medialized single row repair, using a PIC anchors in order to not have any interference at the MRI in the follow-up, and all patients were treated with the bicep tenotomy and the decompression. The augmentation was selected according to randomization by the envelope system, and the technique is called the goalpost technique, and is based on 2 simple stitches medially at the muscular tendon junction, and 2 lateral fixation with 2 crossing suture and 2 knotless metal anchor that we published on WUMED in 2014. In our hypothesis, the first endpoint was to achieve a better tendon healing for a experimental group, and while in the second endpoint, we supposed that in the experimental group, we could have a larger footprint, better MRI tendon sign-on intensity, and better recovery. Our evaluation was carried on at the baseline at 1, 6, 12, and 24 months by an eye-field MRI, and we divided our results in 4 categories: healed, thin but complete, partial, not healed, and not healed at all. For the clinical outcome, we used the VAS, the constant, the DASH, and the SST score at the baseline 3, 6, 12, and 24 months. And these are our results. The descriptive analysis showed us that our sample of patients has been homogeneous in terms of location of the tear and the shapes of the lesion. Also, the Goutalier and the Fuchs index distribution was similar in the 2 groups at the pre-op MRI. With the interferential analysis, the result at 1, 12, and 24 months of follow-up showed a statistical significant difference between the 2 groups in terms of healing when we compare healed versus other patients, and also when we compare healed and thin versus others. Also, the footprint extension showed a statistical difference between the 2 groups, while the outcome had no statistical difference at the VAS score, at the constant score, at the DASH score, and the SST score. In our study, we have no complication. Only 1 patient with a traumatic mobilization of a lateral anchor at 8 months of follow-up required a revision for removing the anchor, and for some interesting biopsies that shown us a good scaffold integration, a tendon-like architecture, a cellularity, and minimal infiltration and degeneration of the tendon. So in conclusion, we can establish that the augmentation provides high healing rates, better repair quality, improved functional recovery. Results are maintaining up to 24 months. Scaffold integrates and the repair show tendon-like feature at 8 months. And it's easy, reproducible, but it's an expensive technique. No complication up to 24 months. And for this year, our answer is that the biological augmentation is very useful in selected cases. The porcine dermal patch, if not cross-linked and with alpha-gal removed, is safe and provide better clinical and radiological results up to 24 months of follow-up. And it could be considered the ideal patch at the moment. Tendon repair without tension with the gold pot techniques is important and provides a good tendon to the bone healing. And the tendon integration to the bone occurs already at 8 months. Thank you very much for your attention.